in case you forgot why you walked in, since you walked in the door. So the agenda for today's class is here. We're going to talk a little bit about the questionnaire that you were handed. I'm going to describe the program here in the Memory Center. I'm going to talk a little bit about advanced healthcare planning. And then there'll be a lecture about memory loss, normal loss with aging versus dementia. So the questionnaire that we handed out, why are we having you fill out this long questionnaire? Such a bother, it seems. But actually, it is critical to our evaluation of people in the clinic. And that is because there is no test that we can run to find out if somebody has dementia. So there's no specific blood test. There's no image that we can do and that will tell us if someone has dementia. The diagnosis is based in large part on history. And that is what family and friends and a person themselves is noticing about problems with memory. So the questionnaire that you fill out is used in our evaluation in the clinic, and that's very important. Also, the questionnaire is used to register you for the class. So if you don't turn the questionnaire in, it is as if you were never here in terms of what the record reflects in the chart. Now, by the end of the class, I want you to answer the question on the very first page, which is not numbered. This question appears in bold, and it asks whether or not you will want to have an evaluation in the Memory Center. Yes or no. Please fill that in before you leave. If you decide that you don't really want to come for the memory evaluation, please turn the questionnaire in anyway, because we will keep that on file. And in a few months, if you decide, you know what, I think I would like to go and have an evaluation, all you would need to do at that point is call us up and schedule the visit. You would not need another referral, and we've got the questionnaire on file. So please turn it in whether or not you decide you want the evaluation, and mark the front of the questionnaire whether you would like that or not. So what is the Memory Center? So the Memory Center is a multidisciplinary team, and we receive referrals from other doctors, usually primary care providers, when there's a concern regarding a person's memory or thinking ability. And the Memory Center team consists of a physician chief, 3 nurse practitioners, 4 social workers, a pharmacist, a program coordinator, and a manager. So we are a large team, 11-member team. And we evaluate people, we make diagnosis of dementia, and then we do ongoing care for the patients who we see and who we diagnose with dementia. And that's ongoing supportive care, often by phone, and we do that indefinitely after we make a diagnosis. And right now we have over 4,200 patients under management in the Memory Center, so it's a lot of people that we take care of there. And this is a picture of some of the members of the Memory Center team. And this is where we are located. We are here at Martinez in the Hacienda building up there on the 2nd floor. So here's a tip. If you come for a Memory Center evaluation, the closest entrance to the Hacienda building is actually on Center Street. Although our address, the campus address, is Muir Road, if you come in and park down there in the parking structure, it's a long walk up the hill to the Hacienda building. If you come in on Center Street, there's parking close by, and it's easier. So as I go along, I also want to mention that a copy of all of these slides is in your packet today. So if you're taking notes, you can make notes right on the slides, and the information is in your packets. And here's a map of the campus here at Martinez. Hacienda is this large building, number 6. So the Memory Center program consists of 4 steps. This class is step 1. So it's our basic introduction to the Memory Center and to memory problems. Step 2 of the program is the in-office evaluation. And that is a very long visit. That's a 75-minute visit. Typically, when you go to see the doctor, you see the doctor for about, 4 or 5 minutes, right? This is a very long visit in the Memory Center, 75 minutes. And during that visit, the nurse practitioner or the doctor will meet with the patient and do the evaluation. Our social worker meets with the family at that same time. The pharmacist looks over all medications and does a thorough pharmacy evaluation at that time as well. And then we all get together, we tell you what our evaluation found, we give you recommendations. So it's a very comprehensive visit. Before the evaluation, we do a thorough chart review, so we are quite familiar with medical history when we meet with you. We look at any lab tests that have been run, any other tests that are pertinent to the diagnosis of dementia. And then during the evaluation, we use some standardized testing tools that help us evaluate cognition, which is just a fancy word meaning thinking. And then we also look at depression. We evaluate depression with a formal standardized tool during that visit. And we do a physical exam, and this physical exam is neurological exam, so it's not a general physical, it's a physical pertinent to the neurological system. So the only definitive test for Alzheimer's or other dementia, unfortunately, is an autopsy. Most people are not in a hurry for that test. And so that's why we need to look at all of these other things, including that history and other aspects from our evaluation in order to make a diagnosis. Hopefully, by the end of that visit, we'll be able to tell you whether we think there's dementia or not. And we might be able to tell you what type of dementia we think that is. We aren't always able to give a definitive diagnosis. It depends on all of those factors. If we need further testing, at that time we will make a referral for any imaging or blood tests. Those things are used to rule out other causes of a cognitive problem. On occasion, we will make a referral for neuropsych testing, neuropsychological testing. That is in-depth testing that takes about 4 hours, and the neuropsychologists are specialized psychologists, and they use tools that really drill down into every aspect of thinking. We only refer people for that if what we see in the clinic and what we measure is not what the family's reporting. When there's a mismatch and we don't understand, this person's scoring very low, but family is telling us that they're still able to function, cook, pay their bills, do things. And at that time, we might need to get a neuropsych evaluation. But it's a long, long visit, and I don't like to put people through that if I don't have to. So step 3 of our program, if a person receives a diagnosis of dementia, we have a class called Dementia Basics, and this gives further education about dementia. It also has a large piece on life care planning, advanced health care planning in that class. And then step 4 is a class just for caregivers, and it has caregiver skills. We go over lots of skills and techniques for taking care of somebody with dementia. Okay, so advanced health care directives. So everybody over the age of 18, which today it looks like that's all of us, should have an advanced health care directive. So what an advanced health care directive is, that is a legal document where you can legally appoint somebody to make your healthcare decisions for you if you are unable to do so. And anything can happen in life. People can get into accidents even when they're healthy, and it's good to have already named a person who will make your decisions for you in that event. In the case of dementia, it's critical because unfortunately, as dementia progresses, people will often lose the ability to make decisions, and including the decision of who they would want to make their decisions. So it's very important to get that document in order. As I mentioned, it's a legal document, so it needs to be notarized. And if it's not notarized, if you're not able to get it notarized, you can have it witnessed by 2 people. Those people should not be related to the person signing the document and should not be named in the document. Sometimes people have an advanced healthcare directive as part of a will or a trust, and that works fine if you have that. You can bring us those pages from the will or the trust that are the advanced healthcare directive. Bring us copies of those, and we can get those scanned into your charts. So we want the advanced healthcare directive on the chart. So if somebody were to end up, for example, in the emergency room, they would be able to see, okay, we know who the durable power of attorney for healthcare is. We know who we can talk to. In this day of emphasis on health information privacy, a lot of times doctors won't talk with people unless they know that that person's been appointed as somebody's agent, and then they'll be able to talk to you about problems. So it's a critical document. Okay, so the lecture today, I mentioned we're going to talk about memory loss, what's normal versus what's not normal. We'll talk a little bit about mild cognitive impairment and also about depression and delirium. Then I'll go into a little more about dementia, the types of dementia, the treatments for dementia. So, how many people in here feel that their memory gets better as they get older? I wish that were true, but it's not true. And that poses somewhat of a challenge for us, because when we see somebody who's older with memory loss, well, that's pretty much everybody is having some memory loss as they get older. So the memory loss that occurs normally as people get older is an issue, we call it an issue of retrieval. So it means that you may not be able to come up with a word, but in a few minutes you will, or an hour later you will. It's also the kind of thing that happens when you think about something and you go to that room because you need to get that thing, and you get in there. What did I come in here for? And you go back to where you were when you first thought you needed to get something and see if that jogs your memory. That's the kind of thing that happens with normal age-related memory loss. So another example would be that you were talking with a friend about a movie you saw, and it was that actress, you know, that young woman, and you can't come up with the name. Half an hour later, after you've gone home, the name pops into your head. That's an example of normal age-related memory loss. So I mentioned that it's a problem of retrieval. And Dr. Klingman, the chief of neurology, described it this way. He said, imagine that in your brain you have the memory file room. So there's a room, and they keep all the files there of what you remember. When you're young, everything's in order. All the files are neatly in order, plenty of room. As time goes on, and you need to remember more and more things, the file room gets to be a bit of a mess. Files are stacked on the desk. Pretty soon they're under the desk, in the closet, and when you go and try to remember something, the little guy in the file room is running around looking for the file. But eventually you come up with what it is you wanted to remember. Now, when there's a problem like dementia, the way we distinguish that problem from normal loss is that, number one, a problem with dementia interferes with function. It actually gets in the way of doing the things that you need to do, your basic day-to-day things. Things like remembering to take your medicine start to become a problem. Remembering that you have an appointment, forgetting appointments, paying bills twice because you forgot that you already paid it, or forgetting to pay it and having your power turned off, or getting into trouble with fees. These are examples of a memory problem that's starting to get in the way of your ability to function. That's one of the distinguishing features of a problem with dementia versus normal memory loss. So as memory declines, we measure this, as I mentioned, on some standardized tests. And these tests are used on thousands of people, and they develop ranges of normal memory loss versus dementia. And there's a place in the middle that we call mild cognitive impairment. So mild cognitive impairment is impairment that is worse than we would expect for normal age-related loss, but not to the point that we call it dementia. So when we test somebody and they end up in that range of mild cognitive impairment, of those people, a third go on and improve in the future. And that's because the memory loss is caused by something that is reversible. And we'll go over some of those things in a minute. About a third of people will stay the same. We're not sure about that group of people. Perhaps they always would have tested at that level, or they may have had one single microvascular event in the brain that's caused a decline, but no further decline has happened. About a third of people with mild cognitive impairment will go on to develop dementia. So for those people, we have taken a snapshot in time, that day we saw them, and at that point their loss was in the range of mild cognitive impairment. But they do go on, a third, to develop dementia. We like to identify people with mild cognitive impairment because there are a few things that people can do to help maintain their brain function, and we'll talk about that as well. So the reversible causes that I mentioned of mild cognitive impairment are listed here. And these are things such as a low vitamin B12 level. If somebody has an extremely low vitamin B12, this can actually impair cognition. Vitamin B12 is essential for the function of nerve cells, and the brain is made up of nerve cells. So if the B12 is low, the thinking can be impaired. We do measure the vitamin B12 level, and vitamin B12 can be replaced, and cognition can improve if that's the problem. Electrolytes imbalance can also cause a memory problem. So that's sodium, potassium, calcium. These are some of the electrolytes in the blood. So we look at blood tests to see if there's an imbalance that could be causing a problem. Those things can be also repaired, and people can be brought into balance with their electrolytes. Sleep can cause a problem. If somebody has a sleep problem like sleep apnea, this can impair function of the brain as well. So if we suspect that there's a problem with sleep apnea, we might make a referral to the sleep center so that they can be evaluated for sleep apnea. There is treatment for sleep apnea, and people's cognition can improve if they have apnea, and that's the cause of their cognitive problem. Alcohol can cause impairment in thinking. It is a brain toxin, and if people are drinking alcohol heavily, this can impair their cognition. And some of that cognition can improve if they stop drinking alcohol. In the case of alcohol, if it's been heavy alcohol use over a long period, unfortunately they won't necessarily get back to baseline, although they can improve from where they are when we measure them. Hearing and vision affect memory. If you don't hear something, you're not going to be able to remember it. And if you don't see it, you won't be able to remember it. So these things also can impair memory, and they can be fixed. Memory might get better. Certain medications can impair memory. Most of those medicines are things that help people sleep or that are sedative. So sleeping medicines and some of the pain medicines, the opiate pain medicines, can impair memory. So depression and anxiety can mimic a memory problem. If somebody has severe depression, they often will not really pay attention to what's going on. People are depressed, sometimes they can't get out of bed, they just don't have any reason to get out of bed, and they're not really paying attention to the world around them. And they'll sometimes look like they have a dementia, but in fact, if we can treat the depression, the cognitive problem can improve. Unfortunately, depression itself is a risk factor for dementia. And that means people who have a severe problem with depression can go on to develop a problem with dementia. And people who have dementia often become depressed. So there is an interaction here between depression and dementia. If we see a person in our clinic and they test in the dementia range on our tests, but we find significant depression, we don't necessarily want to make a diagnosis that day of dementia because we don't know how much of this is being caused by depression. So we'll often make a referral to mental health so that they can get some treatment for their depression and then have them come back to us later and test them again once the depression has been treated. This is a graph that just illustrates the fact that people with depression are at greater risk of developing dementia. So it shows that people with depression develop dementia a little bit earlier age. So what can we do? Well, the person there on your right says, just give me the drugs. But exercise is one of the best treatments that we have for depression. So exercise is very important in that case. So delirium. Delirium is another thing that might look like a cognitive problem, like a dementia. But delirium is an acute confusional state. And what acute means is it comes on suddenly. So dementia never occurs suddenly. Dementia is usually a gradual process. Delirium can occur, especially in older adults, for many different reasons. One reason is that there is an infection. Often, older adults will become very confused and we find out that they have an infection, something like a bladder infection. Younger people will get a bladder infection, they won't get confused, but older people will, and that's a form of delirium. Being in the hospital can cause delirium in older people. The hospital is an extremely confusing place. There's a bunch of people running around who you don't recognize, you don't know where you are, there's bells going off, and older people in the hospital can develop delirium just by being in the hospital. Other things like hip fracture, a person falls, breaks a hip, will often develop a delirium in the hospital while they're being treated for that. So delirium is not the same as dementia. However, people who develop delirium are at greater risk of developing dementia. And our patients with dementia will often develop a delirium more easily than other patients. So once again, there's a bit of an interaction between delirium and dementia. So what is dementia? We keep talking about this thing, dementia. So by definition, first of all, dementia is an umbrella term. It's a general term. And dementia is any change in cognition that is global, meaning that it affects more than one realm or aspect of cognition, and it affects cognition to the point that it interferes with function. So that's dementia, a global change in cognition that interferes with function. And here at the bottom of this slide, it lists different aspects of cognition. That's things that the brain does for us. So in addition to memory, the brain also helps you calculate things, know how much change you should get back at the store. It helps you get around. It stores all the maps. You're not thinking about it, but it stores the map so you know how to get home today from where you are. It does a lot of different things for us. And dementia will affect more than one of those things. So if you have a problem with memory and it's strictly memory and it's not impairing your function, then we don't call that dementia. And here is a diagram of some of the most common causes of dementia. And in the yellow there is the most common cause of dementia, which is Alzheimer's disease. And in this study, 70% of the dementia was caused by Alzheimer's. So it's the single largest cause of dementia. And it's followed here by vascular dementia in the bright green pie circle. And that's stroke-related dementia. So people who have a stroke are at risk of developing dementia. And a stroke means that there's been a blockage in blood vessels serving the brain tissue, and the tissue served by that blood vessel dies off. So people with that problem may develop a problem with language. It depends where in the brain the stroke occurs. They may have another stroke later and not be able to do calculations. The other thing we find is that people can have microvascular blockages, meaning tiny blood vessel blockages, that don't affect large areas of tissue. But if they have enough of those microvascular blockages, it can add up to a problem with cognition and dementia. So in that tan triangle there, the Lewy body dementia. Here in this study, it accounted for about 10% of dementia. And this is a different type of dementia. It's caused by a different protein in the brain. It affects different areas of the brain, but it does cause a cognitive problem that affects multiple realms of thinking and interferes with function. And then in the little red triangle is other, 5%, all other causes of dementia. And here at the bottom of the slide, we list some of those other causes, which are much more rare than the three main causes of dementia. So here's Louis Alzheimer. He is the doctor who first described Alzheimer's disease in 1901. A woman was brought to his clinic, and he followed her for 4 years. She lived at his psychiatric hospital, and he described the behaviors and the things that he saw. And this is a picture of that woman. This is Miss Dieter. She was the person who he treated. And when she passed away, he was able to look at brain tissue, and there at the bottom are his original drawings of what he noticed when he looked at the tissue under the microscope. He saw what we now call plaques and tangles, which are a hallmark of Alzheimer's disease. As I mentioned, the only way we can see these is looking at brain tissue on autopsy. So these are not visible to us in any other way. They are working now to develop some imaging techniques that can look for this on image. But so far we are not able to quantify that on imaging, so we are not using that for diagnosis yet. Alzheimer's disease and dementia is extremely prevalent. So it is affecting very, very large numbers of people. And the greatest risk factor for developing dementia is age. And in this slide, you can see for people age 65 to 74, 3% of the people in that age range have a dementia. By the time we are 75 to 84, 18.7% of those people have a dementia. Now, by the time we are 85 and older, 47% of us have dementia. That is a huge number. So almost 50% of people 85 and older have a dementia. The fastest growing population in the United States is people 100 and over. That's our fastest growing population. In other words, our population is aging. We are living longer, and more people. We have this thing called the baby boomers who are now reaching 65, 70 years old, and it poses a tremendous burden to the society care of people with dementia because it affects so many people. So Alzheimer's disease begins about 20 years before anybody knows there's a problem. And that's what this slide shows us. It begins with the deposition of the beta amyloid in the brain, which I mentioned, and it just goes on here. It tells you that after that the microglial cells are activated, and it goes on describing the physiologic changes. But the point I want you to understand is people are developing the problem 20 years before we know there's a problem. So it's a very long process that finally shows itself as people get older. So what can we do about this? Healthy lifestyle changes. We hear about this all the time, and we kind of discount it often. Oh yes, we know we should be doing all these things. Researchers were actually quite surprised when they looked at some of the healthy lifestyle changes. So that's changing your diet, your exercise, and also being social can help. And what they were very surprised with was the impact of exercise. Exercise, they found, physical exercise can actually slow the progression and slow onset of dementia. I used to do primary care of older adults, and I would always tell people, we do not have medicine that does what exercise does. We just don't. So I urge people, especially those of us in here who are not yet in our 80s, start now, exercise. And for people who are older, if you are able to exercise, very important that you do that. And I usually give a prescription of 30 minutes a day, 5 days a week. And the best exercise is the exercise you will do. That's the best exercise. So it's figuring out what you will do and then doing that on a regular basis. Very important. And that's actually better than medicine right now, exercise. Diet, also helpful. A healthy diet, what we call a Mediterranean diet, is helpful. That's a diet low in sugar, fat, salt, high in vegetables and fruits, with very limited quantities of red meat. And then socializing helps. Social interaction. So people who get out and socialize are actually exercising their brains. And this is where hearing and vision are so important, because if somebody's hearing is very poor, they tend to isolate. They don't go out. They can't hear what's going on anymore, so they don't go out and socialize. So it's very important to treat hearing loss and vision loss as much as you can. It's worth going to the audiologist and getting hearing aids if you're having a hearing problem. So socializing itself, playing bridge, playing games, this can all help keep the brain function as much as you can. It helps you maintain function. It's very true, use it or lose it. So you want to keep engaged. And so exercise is not easy, but many of us want the pill. Just give me the pill. I don't want to exercise, but we really should be exercising. This is an advertisement here for a website from the National Institute on Aging called Go for Life. And anybody can go there and they can get a counselor who will work with them on setting goals for exercise and other healthy habits. So you can check out Go for Life. Okay, so other than the healthy lifestyle changes, what do we have for dementia? And so this is a slide showing all of the medicine that's ever been approved for the treatment of dementia. The medication at the top is no longer on the market. It's already been taken off the market due to side effects. So we have only 4 medications that are approved for the treatment of dementia. The first 3 on this list, donepezil, rivastigmine, and galantamine, all have the same mode of action, and Namenda, which is memantine at the bottom, has a different method of action. So the most recent medicine, the newest medicine we have, is Namenda at the bottom. It was approved in 2003, and this is 2017. 14 years, we still have not had another medication approved for the treatment of dementia. And it's not because people aren't trying. There is tremendous amount of research ongoing. And I might mention that they have cured Alzheimer's disease over 300 times in rats. And the popular press often hears of this, and they'll talk up different cures for dementia. But unfortunately, what's happened is none of those have translated into improvement in people. So the research continues. So those 3 medications here that I mentioned, donepezil, galantamine, and rivastigmine, these are cholinesterase inhibitors. So what they do in the brain is they act to increase the amount of acetylcholine in the brain, and that is a chemical messenger in the brain. So it helps get messages between nerve cells. And in Alzheimer's disease and some other dementias, acetylcholine is diminished in the brain. The other medicine, Namenda, works a little bit differently. It works on glutamate, which is another chemical messenger in the brain, and it is also diminished in dementia. So it has a little bit different action. So what do these medications do? Number 1, none of them cure Alzheimer's disease or any other dementia. So they are not a cure. They are symptomatic relief. And they work in about 1/3 of patients who try them, about 1/3, 30%, which I don't consider a very good effective ratio there, 30%. So when they do work in people, people will find that they might feel a little brighter. Family might notice this person is a little brighter. Memory is a little bit better. The most dramatic things I've heard in the clinic about response to Aricept, somebody who was an avid knitter had stopped knitting with dementia because they weren't able to because of the dementia. When they started Aricept, they were able to go back to knitting. That's an astounding response to Aricept. We don't see that kind of response typically. What we see is that their memory is a little bit better. We also see that people with later stages of the disease might be able to do some of their basic things, getting themselves dressed, getting themselves bathed, a little better on these medicines. So it's not dramatic benefit. And this graph shows demonstrates that. You have your memory declining with dementia, and then that red line is where a person started the memory medicine and there was a little improvement. But they continued to decline at about the same rate. And the little blue line shows that if the medication is stopped, they return to that original baseline. So that shows it's not really affecting the course of the disease. It's kind of a symptomatic treatment. So here it says it can delay worsening of symptoms for about 6 to 12 months. These are not changes that we can measure in our testing. So we don't have patients start the medicine and then come back to our clinic so that we can see, did they get better? Because the changes with this medicine are very subtle and typically are not reflected in improved scores on our testing because it's very subtle treatment. But it can help a little bit with behavior. People with dementia often develop difficult behaviors. They can be very agitated as this disease progresses, can make them difficult to care for, and sometimes these medicines will help with some of those things. So it can help with that. And we do notice that even when we stop the medicine later in the disease, people will sometimes now not be able to dress themselves where they had been able to dress themselves previously. So the medication is doing something, it's just pretty subtle. But I would say it can be worth a try. Question? He mentioned that he has somebody in the family with the dementia who has actually gotten better over time. As this dementia has progressed, that person has become more cooperative and easier to care for. And his question was, is that atypical? Yes, that's atypical. Very lucky there. You're very lucky. Typically, people are not easy to care for. And the problem is, the reason is that their brains are literally shrinking. This disease shrinks the brain. They're losing brain tissue, and they're struggling to make heads or tails of the world. It can be extremely anxiety-provoking when you can't remember this person who keeps coming into the room. People can get very agitated. So your experience of somebody getting better or easier to care for, that's unusual. So you're very lucky with that. And that's, I'll be mentioning that at the end. That is why our classes are important, because we talk a lot about what's really happening in the brain and explain this is why people are the way they are with dementia and how to communicate with them. And that can help a lot as you take care of somebody with dementia. So at the bottom here, we mentioned the side effects of the medication. So I would like to say that 30% of people who try this medicine have a benefit. They feel better. 30% who try it have a side effect that they cannot tolerate. And the most common side effects are GI related, meaning upset stomach and diarrhea. But you can also get headache, dizziness. It can affect some heart problems, specifically heart rate. Can be a problem. Question? Right, so a question about clarifying what I said about the 30%. So if you have the group of all the people who've tried the medicine, about 30% of them have a benefit. Another 30% had a side effect they couldn't tolerate. And about the remaining 40% have no response. So that's the picture of these medications and how they work. So this is an analogy. You're in a boat with a leak and you're bailing water. And that's kind of what you're doing with these medications. And eventually the boat's going to sink, but it might sink a little bit slower. And this is a very busy slide. I don't expect that you'll be able to read anything on here, but these are drugs in the pipeline, some of the current drugs in the pipeline. And I include this slide only so that you realize that there is an awful lot of research going on. People are really working on this issue. You can imagine that the company that makes a medication that has a real benefit, that company will mint money Absolutely. This is a problem affecting such a large percentage of people, and it has an amazing cost burden. The problem has amazing cost burden, so if they come up with a treatment, it will be very popular. I do go to conferences all the time on dementia, and the current thinking is that the answer to this question is going to be multi-pronged. So the researchers do not feel that they're going to come up with one medicine that's going to cure this disease. They currently feel that this is going to be multiple medications that affect these pathways in the metabolism of these proteins at different points. So I want to mention some medications people should avoid. And number one here are the benzodiazepines. This is things like Ativan, Valium, Xanax. Those are all benzodiazepines. Those medications are prescribed often for anxiety, sometimes just for sleep medicine. And the thing about the benzodiazepines is even when a person can take that medicine when they're 50 and that they do fine, when you're 80, these medicines are not good for you. They will increase confusion and fall risk. So we talked about how the memory medicines work to increase acetylcholine in the brain. The benzodiazepines work exactly opposite. They decrease acetylcholine, so we want people to avoid those medications if possible.
You mean a little Benadryl for allergies?
Right, and so this lady's pointing out the next item on the list is Benadryl, which is something used for allergies. It's also known as diphenhydramine, and it is also anticholinergic, meaning that it decreases acetylcholine in the brain. And Benadryl is in many, many medicines that you can buy over the counter. It's like Tylenol PM, Advil PM, anything PM, Sleepies. These are all diphenhydramine, which is Benadryl. And so we'd like people to avoid that. Some people want to know, okay, well, if I'm not taking Benadryl for allergies, what should I take? A couple of the other antihistamines are a little better, less anticholinergic than Benadryl. Things like Zyrtec or Loratadine, which is Claritin, are a little bit less anticholinergic. Now, there are times when a person needs to take Benadryl, and that's usually when somebody has a significant allergic reaction. Some people take Benadryl after a bee sting because they know that they are going to have a bad reaction. That's different. Of course, you would need to take the Benadryl at that point. But what we want to make sure that people know is if you're using night after night Sleepies or Tylenol PM or something like that, it can actually cause some damage in reducing this neurotransmitter that's so important in the brain. Oh yes, melatonin is a natural hormone, and that occurs in all of our brains, and it's very important in the sleep-wake cycle. And as we get older, melatonin decreases in everybody. So melatonin is available over the counter, and it's the first agent that we recommend when people are having a hard time with sleep. And I would also add, look for the sustained release form, the extended release form. It tends to be a lot better than the regular form of melatonin. So when we see patients and there's a sleep problem, melatonin is where we usually start. And I might add, unfortunately, dementia causes a problem in sleep-wake cycles. So it's part of the disease. Question? So the question was, what about Ambien? Ambien is actually more dangerous than the benzodiazepines. So I would not have any older adult taking Ambien. And when we say older adult, that's people generally 70 and older. But Ambien can definitely cause confusion. It can cause effects the following day. I actually had a coworker whose husband was taking Ambien. He got up, got in his car, was sound asleep, got in the car, drove the car down the freeway and got in a head-on collision. And it was because he was taking Ambien. It's a hypnagogic agent, and we don't recommend it. So we try to avoid it.
Wipes out your memory, doesn't it?
So yeah, Ambien is not good for memory. Oops, skip the slide. So driving. As you might imagine, as people develop dementia, their driving might become unsafe. So in the clinic, anybody in a clinic, any doctor, nurse, anybody, is what we call an obligated reporter. California is an obligated reporting state, and that means that if we see somebody and we're concerned that they may be unsafe driving, we are obligated by law to let the Department of Public Health know. And so if we see people, and if we give a diagnosis of dementia, then we are obligated to let the Department of Public Health know that. We do not evaluate driving. The Department of Motor Vehicles does that. So we are just obligated to let them know when we're concerned that there may be an issue with driving. And this slide is listing the warning signs of unsafe driving. And so there are many of them. Our favorite one is family and friends are afraid to drive with the person. So if that's the case, there's probably an issue with driving. It's a very touchy issue here in our society. Driving represents your independence. It's how you get around in the world. And it can be a very touchy subject. But we don't want somebody driving who is at risk of injuring themselves or other people. So we do look at that question in the clinic. We have had patients families have gotten a call and the patient doesn't know where they are or how to get home. We've had people drive as far away as 200 miles and not know where they are or how to get home. Or people who don't come home and a search needs to be undertaken to find them. So driving is actually quite a complex task for the brain. The brain has to look at the cars around, know the laws, react to the changes in speed, etc. So it's a very complex cognitive task, and one that somebody with dementia will eventually not be able to do. So, in conclusion, not all memory problems are dementia. We talked about the fact that there is memory change with age that is normal, and there are other causes for cognitive changes. And then we talked a little bit about dementia, which is not the happiest subject in the world. It's a devastating neurologic disease for which we don't have great treatment. Alzheimers.org is an amazing website. The Alzheimer's Association is an amazing organization. They have free classes, support groups, they support research. They have a 24-hour helpline. So I like to have people aware that if you have any questions before you see us or even after you see us, you can always check out the Alzheimer's Association website. So do people remember what are the 3 things you need to bring to your visit in the office? Who remembers?
Medications.
Yes, medications. So I want to make sure you bring your medications. That's all the medicine that the person's taking, whether it's a prescription or over the counter, whether it's just as needed or a regular medicine. We want you to bring all of those medicines in their actual containers, and the pharmacist will look those over. We want you to bring a person with you who can help with the history, so that's a family member or a friend. And then the last thing, if you have an advanced healthcare directive, we want you to bring a copy of that with you to your visit. So those are the 3 things that I want you to bring to your visit.